I often hear this phrase, antibiotics save lives in certain cases. And I am on a continuous journey to substantiate or to understand if that statement is in fact true. One thing that has piqued my interest is, well, what happens whenever a patient is in sepsis or they are in, their body is shutting down, they're in organ failure, their blood pressure is dropping, and the doctor's telling you need to take an antibiotic because you are about to die. Like, what is really happening? Are we saving lives there? Of course, a conventional doctor will say, of course we are. I see people get better after giving antibiotics, but we have to define what better is. We have to define what work means, something working, and seeing beyond just a few days of someone having a suppression of symptoms for that, small window of time. Now, it does seem evident that antibiotics will suppress symptoms, but many things suppress symptoms, and that does not equal, vitality, health, wellness, recovery, and addressing what's actually happening. So I wanted to share with you, when you start digging in these things, it becomes fascinating, because if you just read the abstract, or in fact, for this one, I particularly was just reading like on a blog or something, and they take things out and they say antibiotics, save lives. Like if you Google that phrase, you can find all kinds of pieces from different articles, from different universities, from different practice guidelines that will say, yes, of course, you need to give antibiotics early on in sepsis, and the earlier the better. And okay, rightly so. Perhaps that does help in those acute situations to buy more time, if you will. Even if there is long-term damage, well, at least you've bought some more time to be able to address maybe some underlying factors. That is a reasonable thing to think, and that could very well be possible. One of the things that they will talk about in some of these studies you will see is delay in treatment for people who enter the ICU and do not receive antibiotics immediately. Other studies have reported that more aggressive antibiotic regimens may be associated with higher mortality rates in critically ill patients. So critically ill patients, higher uses of antibiotics. Multiple studies have found that there is a higher mortality rate when using antibiotics in those patients. Unnecessary antibiotics may also increase the risk of acute kidney injury. We observe a trend more towards acute kidney injury in patients treated with broad antibiotics. That was a lot. So here's another review that I found. This is a 2015 study, and it's a systematic review and meta-analysis. So they looked at the association of timing of antibiotic administration and your risk of death due to sepsis and septic shock. That's the ultimate deciding factor on if antibiotics save lives. Like if they're going to save lives, they're going to save lives here and now in sepsis. Okay, like this is it. So when we look at this study, it says over a total of 1,100 publications were identified. 16,000 patients for antibiotic administration from emergency department. Patients who received antibiotics more than 3 hours after emergency department triage, had a pooled odds ratio for mortality of 1.16. Total of 11,000 patients had antibiotic administration from sepsis. And those who received antibiotics more than 1 hour after sepsis had a pooled odds ratio of 1.46. There was no increased mortality in the pooled odds ratio for each hourly delay from less than 1 to more than 5 hours in antibiotic administration. Using the available data, we found no significant mortality benefit of administering antibiotics within 3 hours of emergency department triage, or within 1 hour of shock recognition in severe septic shock. These results suggest that currently recommended timing metrics as measures of quality of care are not supported by the evidence. My goodness, even I'm shocked by that. And now the last study that I want to address is one that was after the previous study that I just shared with you. The review article, The Impact of Timing of Antibiotics on Outcomes in Severe Sepsis. Now you have a couple of scientists here that wrote an open letter to the editor in relation to that particular study. And so I will read that here. So you can see this is an open letter to the editor, time for a randomized controlled trial to investigate optimal time to antibiotics for patients with sepsis. Okay. And they write, in a recent issue of Critical Care Medicine, we read with great interest the study by Sterling and others in which they investigated the association between timing of antibiotics and mortality in severe sepsis. Okay, we just read that article. Previous studies investigating the effects of time to antibiotics on outcomes had inconsistent results. Some suggesting that delayed antibiotic administration is what led to a dramatic rise in mortality, whereas others found no difference. The research group carried out a robust systematic review in which they give a comprehensive overview of available data, concluding that in patients with severe sepsis and septic shock, antibiotic administration within 3 hours of emergency department triage or within 1 hour of shock recognition is not associated with significant improvement in mortality. Timely administration of antibiotics is seen as a cornerstone of treatment for patients with sepsis. However, a definite answer to that question, what the best timing of antibiotic administration is, only can be obtained by a prospective randomized controlled trial that avoids selection bias. However, as authors mentioned, it may be unethical to do that type of study. An alternative option is to perform a prospective randomized trial in the pre-hospital setting, that is in the ambulance. In current practice, initiation of antibiotic therapy starts in the emergency room and not in the ambulances. So this researcher is saying, okay, well, I hear that that's what you found in your study, but maybe if we give the antibiotics even earlier, maybe we can just give some people treatment in the ambulance and some people don't treat them until they get to the emergency room. And we'll see if giving them early antibiotics will help mitigate any risk in mortality, any higher risk in mortality. Okay, this is what these couple researchers went out and set out to do, and they did that. This is in the Lancet. Pre-hospital antibiotics in the ambulance for sepsis, a multi-center open-label randomized trial. Great. So they trained EMS personnel to recognize sepsis. Then they looked at 34 secondary and tertiary care hospitals that these ambulances served in 10 large regional ambulance services in the Netherlands. They compared the effects of early administration of antibiotics in the ambulance with just waiting until they get to the hospital, and the hospital gave them antibiotics in their standard of care, which they're supposed to do so within an hour of any signs of sepsis and within 3 hours of being suspected of having sepsis, I believe is the standard of care. They did their analysis and they found the following. In patients with varying severity of sepsis, EMS personnel training improved early recognition of sepsis and care in the whole care chain. However, giving antibiotics in the ambulance did not lead to improved survival regardless of illness severity. Now, you had a review that looked at multiple studies and found no difference in mortality. And then now you have a randomized controlled trial that thought, okay, well, maybe if we give the antibiotics even earlier, because that is the premise that it's about timing, which is why they give antibiotics and give broad spectrum antibiotics very quick on. They are saying that no, there is no difference in mortality, even when they are given immediately, even in the ambulance setting, in the pre-hospital setting. I tend to lean towards that antibiotics on their own are not a reason for saving someone's life, that there are so many variables in the mix that we cannot make that statement accurately, that Perhaps for a certain individual that could be true, but across the board, generally speaking, that does not seem to be the case in what I have found. This is not medical advice. This does not mean if you feel the need to utilize that type of treatment, or if you have utilized that type of treatment, that you are bad or you were wrong or that you were stupid. None of that is the case. We are all learning here, and this is an educational resource to understand some of the treatments that we have been touting and screaming from the rooftops are, savers of so many human lives over the years and animal lives at this point. Is that statement really true? That is what I wanted to get to the bottom of. And I will continue to dig and search and look and learn and unlearn to find more information on this topic. But this is where I stand as of now.